Hi, everybody. Want to talk a little bit about SAT and SBTs and just kind of touch up on that since we have a lot of new people and we haven't talked about it in a while. And we're actually making a few changes to the way that we're doing things. So just from the top, I know most of you know this, but an SAT stands for Spontaneous Awakening Trial. SBT stands for Spontaneous Breathing Trial. Those two things are geared to minimize the time that a patient is on a vent. So whenever you do an SAT and an SBT on a patient, it's so that we can see if the patient is ready to come off the vent and be extubated. Our vent days are a little bit higher than we should have them. We don't think that that's a process issue, but there are some things that we can change to make that a little bit better. And so the first thing we're going to do is we have been unofficially doing SATs and SBTs in the morning and at night. I know that in CCU the process has been like that for a while, where they do an SBT documentation, SAT, in the morning and in the evening, except we never followed through with it in the evening. So now that's going to change. Starting immediately, we are going to start doing SATs and SBTs in the morning and in the evening. And if a patient passes their spontaneous breathing trial in the evening, they will be extubated. They will not wait till the next day because that's an extra vent day that we could have avoided, and a lot of complications that we could avoid if we can extubate those patients. So how are we going to do that? The main key is communication with RT. So the first thing that we're going to do a little bit different is every day at 5 in the morning and at 5 in the afternoon, we are going to start our SAT screening process. That doesn't mean that that's when we're going to do the screening, right? We're gonna say, okay, it's 5 o'clock. Let's identify these patients that are on vents and start that SAT screening process. If the patient meets criteria, passes the SAT screen, right, then we're going to move to an SAT. Let's say at 5 o'clock you have a patient and you determine that this patient is appropriate to conduct a spontaneous awakening trial. If the patient is on propofol, you don't really want to start you don't want to turn that off at 5 o'clock, because what's going to happen is the patient is going to be ready for an SBT in 20 minutes. And by 6:15, the patient might be ready to be extubated, maybe 6:30, and that is a bad time to extubate somebody. So we want to time turning off the sedation so that the patient is not only not ready at 6 o'clock, 6:15, but that the patient is not anxious and pulling his tube out while you're giving report, okay? So that is something that you have to use your judgment. And, for example, if the patient is on fentanyl and Versed, you're going to turn off that Versed and fentanyl at 5 o'clock, maybe even 4 o'clock. But if the patient's only on propofol, maybe on a little bit of fentanyl, you're going to wait a little while to turn that off, and you're going to gauge how the patient is reacting to that. Now, if a patient just came from surgery, if a patient just got intubated that day, you're not going to do an SAT on that patient. That patient is going to fail the trial. So make sure that you're paying attention when you're filling out the trial, because those patients are excluded from needing an SAT and an SBT. So it's a first day of event, and if the patient had surgery that day. But you're still going to do your SAT screening, and that'll guide you to where it meets criteria or not. Now, how are we going to communicate with RT? Well, we're going to do two things. The first thing we're going to do at 5 o'clock, when the SAT screening process begins on all of our vented patients, the charge nurse will identify the patients that will most likely pass the screening and need an SBT. Let's say that we have 12 vents on the unit, and 5 of those, we know those patients are not going to be extubated. And another 2 or 3 of those, we're not sure, but we're going to do a trial. And then there's like 4 that we know these patients can probably come off the vent. So the charge nurse will send a broadcast to RT. around 5 o'clock, 5:15, with the room numbers of the patients that we are going to try to perform an SAT. We don't have to give them at that point specific information on whether the patient is going to pass it or not. We just need to say, hey, these are the ones that are getting a trial tonight. So then RT will pass that along to their next shift. Remember, RT changes at 6 o'clock. So the oncoming shift from RT will have a list of the patients that they need to round on first to start the SBT process. And if you are the nurse performing the spontaneous awakening trial, and your patient seems to be waking up right away or tolerating it well, and you think this patient, needs to have the SBT, then you will communicate directly with your RT and say, hey, 16, I think he's on your list for SBT, and I turned off the propofol an hour ago, and he's ready to go. So it's up to you to communicate with the RT once the patient is ready for his spontaneous breathing trial. And of course, if we do extubate a patient, make sure that RT knows we want them to be there. Sometimes they can't be there during an extubation, but you should call them, hey, we're extubating 17. So same process for CCU and ICU. RT is going to get this video, and we have communicated with them the process of our 5 o'clock and 5 o'clock texting. We will start that on February 1st, which is tomorrow for me now. So don't worry about it tonight, because we want everybody to get this message first. And we think that that's going to help get a few more patients extubated at night shift. Now, please be conscious of the night shift doctors. They come in sometimes to a big mess, and they're very busy in the beginning of the shift. So the closer to the beginning of the shift that we can get these patients extubate, the better it is for them. I would say anything before 8:30 is the ideal. After 8:30, it's really hard for the doctors to be assessing these patients right away. Like, they can get to them, but they may not be able to get to them for a while. And then at that point, you have a patient extubated at 10:30 at night. That's not the best time to extubate, because that patient's going to be awake for another 4 or 5 hours trying to recuperate from the extubation. And if something goes wrong, it's just not a good time. So remember, try to time it. And I know this is not a science, and every patient is going to be different, and we're going to have struggles, and we're going to have some patients that completely just mess it up and want to be extubated at 9:30. But for the most part, we should be able to accomplish getting a few more patients off vents. I need feedback. If you get any pushback from anybody, RT, let me know if nursing is not communicating. Nursing, let me know if RT needs to, maybe there's a different way that we can communicate with them. I'm open for all your ideas. And also let me know if the provider has an issue with the process. They should be on board. We have had meetings with them, and they are all aware that we are going to be starting this process right away. And just as a side note, make sure if you are documenting an SAT screening and the patient passes the screening, you must document an SAT. If you don't document an SAT on a patient that passed the screening, that's a fallout. So that is a must. You have to do the screening, and if it fails, you're good, you're done. If it doesn't fail, if it passes the screening, document an SAT. Anyway, I hope that gets us started on the right foot. We'll talk more about this. I'm sure that we're going to have some bumps in the road anytime that we implement something new. That is expected. So please don't get frustrated. I just need the feedback so that we can adjust as we go and come up with the best process. One last thing. Our average RAS right now for the unit for the last few months is -3. That is way too sedated. Our goal for this patient should be -1. That is our goal for ventilated patients. I see most patients that are on vents are just knocked out, and a lot of them not restrained. And we don't have that many self-extubations, which is kind of good, but not really. Our self-extubations should be a little bit higher. That's an indication that our patients are over-sedated, and the negative RAS of 3 is just way too much. These patients should be, especially surgical patients, abdominal surgical patients, they should be getting up. They should be reading the newspaper during the day on the vent. Is there even newspapers? I don't know. The internet news, whatever. Or TikTok. but they really should be more interactive during the day. That avoids delirium, that promotes healing, and we should be using the convolizer with these patients, even on ventilators, especially if they have a trach on a vent. Those patients should be up every single day. So we'll talk more about RAS and CAM scores pretty soon. I want to make a very detailed video about that because I think we can optimize that a little bit. But anyway, I just wanted to give you that update, and please give me feedback. Don't get frustrated. There will be bumps. I just want to make sure that we, get the feedback so we can make it better. Thanks.